Hi, everyone. Thanks for being here. I'm Yalda Jabbarpour. I'm a family physician. I still work clinically at Georgetown, to Sean's chagrin, but I'm also director of the Robert Graham Center for Policy Studies and Primary Care, which is part of the AAFP. So I'm going to present to you not the stories, but instead the statistics that hopefully the stories that our panelists share will be based upon. I'm sure that these news headlines, which are not as positive as the ones Q showed about primary care in the last year or so, are a surprise to no one. No one who is practicing primary care, and certainly no one who has tried to access primary care within the last couple years. I hear it from my patients all the time. They have to wait months to see me. When they have new friends who move into the area, they're telling me those friends are waiting 9 to 12 months to see a primary care physician. And I do not live in a rural area. I live in Washington, D.C., where you can throw a stone and hit a doctor. So it is unbelievable that people are having to wait so long to see primary care. But it's not only the stories. We actually have the data to back this up. We looked at the medical expenditure panel survey over the last decade and examined the percentage of adults in blue and children in orange who do not have a usual source of care. That number has gone up over the last decade, and right now we're close to about 30% of US adults that do not have a usual source of care, and over 13% of children who do not have a usual source of care. And considering that we are an aging nation with more chronic disease, more mental health needs, immunizations that are not being met, and we're having a measles crisis, it is really, really concerning that this many Americans don't have a usual source of care. And when we look at visit patterns, we are seeing something similar. I think it's no surprise to people in this room that visit numbers for primary care are going down, but I want you to focus on those two red boxes there. The left is primary care visits, the right is subspecialty visits. As is expected, between 2019 and 2020, when we had the COVID pandemic, there were less office visits to primary care and subspecialists. So we expected that. We expected to see that fall. What we did not expect is that there really has not been a rebound for primary care with the advent of the vaccine. So we're still below where we were during COVID for primary care visits, whereas the subspecialists have rebounded. And when we look at this a little bit more closely, what type of visits are we not seeing? Well, we looked at the same data set and we saw that primary care preventive visits are going up, but what's going down is acute care visits and chronic care visits. So over the time period studied, that blue line shows visits to primary care physicians. We're dropping almost in half for acute care visits, and our chronic care visits are going down too, which really begs the question. We're supposed to be the first contact, continuous, comprehensive providers, but if our acute care visits are going down and chronic care visits are going down, what is happening? So people can't get in to see their primary care clinician, less people have a usual source of care. At the same time, visit numbers are going down, and for those of us that work in primary care, that seems crazy because we're busier than ever. So how do you reconcile what's going on in primary care? I think we're seeing these trends because of 5 reasons that I'm going to show you here. This is presented in the Milbank and Physicians Foundation report that the Robert Graham Center produced. The primary care workforce is not growing fast enough to meet population needs. The number of trainees who enter and stay on the professional pathway to primary care is too low. The United States continues to underinvest in primary care. Technology has just become an added burden to primary care. And finally, primary care research to identify, implement, and track novel care delivery and payment models is lacking. So let's start with workforce. Here we look at the number of primary care physicians per 100,000 population over the last decade. A decade ago, we were sounding alarms that we did not have enough primary care physicians to meet the needs of the population. And today, even though we have a sicker population with more needs, our primary care numbers have actually gone down instead of going up. Now, when we add nurse practitioners in primary care and physician assistants in primary care to the physician number, At first, this may look like really good news. We do see an increase in the total number of primary care clinicians who are providing care to the population. But is it enough? The answer is no. Every other country is producing more primary care physicians than the US. In fact, if we look at our neighbors to the north, they are quite literally on a different scale. You can see that Canada is off the chart there. They're producing about 130 family physicians per 100,000 population, whereas when you look at the US, combining physicians, nurse practitioners, and PAs, we're only at about 105. Oh, sorry. But there is a glimmer of hope, probably because of our community health centers. So what we wanted to look at was how primary care was distributed. And compared to other specialties, primary care is actually pretty equitably distributed. What we did was use something called the Social Deprivation Index that was created at the Robert Graham Center. This index is a measure of different factors at the community level that impact health but are not health care. So percent living in poverty, housing, access to transportation. We divided counties in the US into highly socially disadvantaged areas or low socially disadvantaged areas using the SDI. And then we calculated the primary care clinician ratio per 100,000. And you can see there, the orange line is actually the highly disadvantaged areas, and the gray line is the lower disadvantaged areas. And surprisingly, there's actually more primary care clinicians per 100,000 in highly disadvantaged areas. This is great news because we know that patients who live in those areas also have higher medical needs. But is this enough? Once again, it's not. At the highest level, we're at 111. Canada's at about 130. That gap between 99.5 in the low disadvantaged areas and 111 in the higher disadvantaged areas, is that enough to fill all the needs that patients with social vulnerabilities have? Probably not. And why do we not have a robust workforce? Well, it starts with training. So here, we actually examined the growth of residents over the time period of about a decade. We know that there are more residents in the United States overall, but we wanted to look at whether primary care resident numbers were growing as fast as subspecialty resident numbers. And the answer is no. So even though we do see a growth in that blue line of primary care residents per 100,000 population, that orange line is growing much faster, as you can see in the gap between the two. And what else do we know? We know that just because someone trains in primary care does not mean they actually work or stay in primary care. This is particularly true for our internal medicine and pediatrics colleagues who do tend to subspecialize. So we wanted to look at 3 to 5 years after graduation from residency, are physicians actually staying in primary care? That blue line is looking at primary care physicians plus hospitalists. That orange line is if we take the hospitalists out. And it's pretty alarming that, depending on the year that you look at, only between 11 and 15% of all medical trainees are actually entering primary care. And when you look at the other end of the spectrum, retirement, this problem is even worse than we thought. So that blue line is basically from the graph that I showed you before. That's the inflow into primary care, those blue boxes. The greenish teal boxes are outflow, assuming a retirement age of 65. Now, I know that some physicians stay past 65, but there are a lot of physicians, especially recently, that actually are retiring before 65. So if anything, this is probably an underestimate. That black line is the net negative. Once again, we were sounding alarms a decade ago, and that net negative is actually getting worse. So why is this? Why are people not going into primary care? Why is our workforce shrinking? Well, I think one of the reasons, as Q put it, is that we are just not investing enough in primary care. When we looked at our narrow definition of primary care investment, which at the Robert Graham Center we define as total outpatient health expenditures to primary care physicians, including general internists, general pediatricians, family physicians, and GPs, we find that all payers combined, that blue line, we're only spending about 4.7% of total healthcare expenditures on primary care. We don't include nurse practitioners and PAs in this definition because in the data set that we use, we can't actually tell if they're working in primary care, if they're working in a GI office, if they're working at an outpatient surgical center. But we do include them in our broad definition, and even there, we are spending nowhere near other countries on primary care. And what about digital health? There was the promise that digital health would actually help make things more efficient in primary care, in medical offices altogether. It would maybe increase access for patients because they could do things like the patient portal, asynchronous communication. Has it done that? Well, the answer is probably not in the way that it is currently configured. So this data is from the American Board of Family Medicine that surveyed family physicians and found that nearly half of family physicians rate their EHR usability poor or fair, and more than 1/3 of family physicians were not satisfied with their EHR. So currently, the way the EHR is set up is just an added burden to primary care. And finally, what about research? What about researching those innovative models of primary care that can be spread? Are we investing in that? Again, the answer is no. When we look at total federal funding, so this includes NIH, CDC, FDA, and AHRQ, towards primary care research, we're only spending 0.33% of total federal healthcare research funding on primary care. So the largest care delivery platform in the United States is getting less than 1% of total healthcare research dollars at the federal level invested in it. So let's go back to the beginning. What is the current state of primary care? We have an insufficient workforce. We have not enough trainees choosing primary care. We have a lack of investment to support teams. We have digital health that adds to workload instead of supporting primary care. And we have no support to study models of care delivery and payment solutions. But I don't want to end on a bad note. I don't want you guys to run away from the Robert Graham Center or me every time I come in. So let me give you some solutions that the panel will hopefully expand upon. So what can we do about the workforce? We can advocate for payment models that support team-based care. We really need a team to meet the demands of the patients in the United States today. We can support training models that produce primary care clinicians. Q talked about one of those, teaching health centers. Our current GME funding goes mostly to large academic health centers and hospitals. They are not producing primary care clinicians. Teaching health centers are. We can support legislation to measure and increase primary care investment at the state level. Many states are already doing this. We just need to spread it. We can increase the number of primary care clinicians who are involved in the study, design, and implementation of EHRs. Every health system should have a primary care clinician sitting at the table when you're rolling out an EHR. And finally, we can increase funding for primary care research. We now have a National Center for Excellence in Primary Care Research at AHRQ. That's great. But they're only allocated $2 million and a staff of 1. So that's what we're spending on primary care research. So we need to increase funding for primary care research to study models that we can scale. So I hope I'm not leaving you on a sour note. There are things that can absolutely be done. A lot of the data that I showed you here, once again, is from the Milbank report and dashboard. You can look up the state of Tennessee on the dashboard and see where you compared to the national average. So please do that. And thank you very much.